Take the next 15 minutes or so and learn about an important publication on chiropractic physician services for low back and neck pain. The title, Do Chiropractic Physician Services for Treatment of Low Back and Neck Pain Improve the Value of Health Plans? Noteworthy is that the Mercer report refers to chiropractic physician care, not chiropractic care. This is a very strong statement intended to get the attention of politicians and healthcare policymakers. Subtitle, An Evidence-Based Assessment of Incremental Impact on Population Health and Total Healthcare Spending. In other words, if chiropractic care for low back and neck pain was included in U.S. healthcare plans, what would be the cost-effectiveness of that inclusion? Quite a lofty research question. How do you begin? What data do you need, and how do you measure cost-effectiveness and value? It seems someone would have done this by now. Well, they've tried, but we'll see later why this is so difficult. First, let's start with the chiropractic headlines based on the executive summary of the study. Chiropractic care is more effective than other approaches for treating low back and neck pain. When considering cost effectiveness and cost together, chiropractic care for neck and low back pain is highly cost effective, representing a good value in comparison to medical care. Reading into the article, we find that because they were unable to include in their calculations the cost of drugs associated with medical physician management and the decrease in medication utilization by chiropractic patients reported in some studies, it's likely that the cost effectiveness is even more considerable. This is exciting information, but we must stop with a reminder here that it is a report that was commissioned. Its purpose was largely informational for an unaware, mainly apathetic political audience. Chiropractic was not even on their radar. The possibility that chiropractic management of spinal conditions could significantly impact expenditures and assist with the healthcare dilemma was not even a consideration. Well, hopefully the Mercer report will influence and inform politicians and other healthcare policymakers about the potential impact of chiropractic care inclusion. That was its intention. The Mercer report also gives an opportunity to, in short order, summarize the extent of the financial expenditure for back pain, a staggering $85 billion per year, and the effectiveness and cost-effectiveness literature for chiropractic. They added to this summary a consideration of value, using an approach that's gained some popularity in predicting patients' judgments of life quality related to their health. It's called a QALY, or Quality Adjusted Life Year. When apportioning healthcare dollars, cost-effectiveness is not the only consideration. How cost translates into value based on patients' attitudes toward their health and function is increasingly recognized in research in an effort to determine allocation of resources for health coverage, even in the U.S. A few research groups have attempted to answer one or the other part of the research question posed by Mercer, one effectiveness and the other utilization and cost, but not necessarily measured based on value to the patient. The first attempts were two California studies comparing patients who opted for chiropractic coverage in a managed care plan. What was demonstrated was less cost for those using chiropractic services and decreased utilization of imaging, hospitalization, and surgery. Sounds great. What could be wrong with that? Well, like many studies that are not randomized, patients' choices may influence their perceived response to care. Selection bias is the research parlance used to describe this. If I believe that chiropractic care can save me from the medical approach, I may respond more positively, partly because of that belief, or I'll answer a questionnaire more positively because I want to believe that I'm better. Well, the same principle is in play for all participants, though. Utilization of hospital services, in particular surgery, may indicate the patient's decision to use this resource with the belief that it will be of more benefit, which influences their responses also. Some might argue that perhaps this isn't a bad thing. Allowing patients to choose their type of care may increase the success of that care. It's certainly been a model in some countries, such as Germany. Well, in any case, from a research perspective, bias is a no-no. You're required as a scientist to eradicate any bias you're aware of in an attempt to discern the true effect of an intervention, that related directly to the intervention. So now Mercer. How can they avoid these pitfalls or weaknesses of earlier studies, and what advantages do they bring to the table? Well, first, Head the team with two highly respected medical doctors who are experts in the economics of healthcare, Nitish Choudhury and Arnold Milstein. Next, utilize the resources of Mercer. A subdivision of Mercer, Mercer Health and Benefits, is a global company based in the U.S., serving as a health benefits consulting group for large employers, representing 10% of the U.S. employer market. It has over 150 offices worldwide. This in-house data source allowed the use of existing data on billing accessible to Mercer from 80 large employers covering over 3 million member lives. Next, the team accessed and analyzed effectiveness data for chiropractic management of low back and neck pain and included some higher quality European studies. They relied heavily on two studies, the UK BEAM study and a similar Dutch study. Crucial to their process was to utilize a model that could take all of this information and crunch it into a value-based projection. This last element is a relatively new approach being utilized in value-based healthcare research. It attempts to estimate the comparative value of various management choices, in particular for chronic health problems. It's called a QALY. QALY, Quality Adjusted Life Years. Finally, you need funding. Here's where some criticism will arise. This research project was funded by the Foundation for Chiropractic Progress, a unique consortium of all the major players in chiropractic, including the ACA, the ICA, Congress of Chiropractic State Associations, and various colleges, organizations, and individuals. Bias will be sounded as the warning here, but let's take a look at this. They're certainly not trying to hide their affiliation to the project. They even advertise their support on the title page of the report. There's nothing clandestine here. It's clear that the consortium is not attempting to fund an intervention study and muck with the results because of bias. This research attempt appears in fact to be an honest attempt at looking at what the existing data has to say and using that data to project a value determination cogent to the political ear. This is not to say that there aren't some Achilles heels in the science of the conclusions. Well, what adds to the credibility of this defense is the research team. Had there been no evidence for the conclusions, they would have said so, having no vested interest in the outcome of the study. In fact, they looked at the available data before even taking on the project. Mercer was simply enlisted to do the work, in essence, the contractor for this project. Everyone was fully aware that this report was not being submitted for publication in a respected medical journal for peer review, and the inevitable criticism of method. What I mean here is the executive report has no real abstract. It's lacking in explanation of how certain conclusions were arrived at, how certain calculations were performed, and finally no statistical data reporting, such as analytical models and formulas that were used, not even confidence intervals to suggest the range of findings. Not very scientific for a scientific appearing report. Well, that being said, the report was based on other research that was scientifically scrutinized. You will see in the article incremental cost-effectiveness ratios. Well, what does that mean? It's the difference in total cost of care between or among different interventions. In this case, between medical care and other modalities for the same episode of care. But what's unique is this is matched with effectiveness differences also. This report is an example of cost-utility analysis. The objective of cost-utility analysis is to evaluate the costs and consequences, which include benefits and potential complications of using a health intervention in an effort to objectively apportion healthcare resources. QALYs were created to pull all health outcomes into the same frame of reference. First, individuals use a measure which represents the morbidity of a disease state that incorporates a scale of 1 as perfect health and 0 as death. There are numerous approaches to gauging a patient's value rating of the quality of their life. An example might be that a patient with diabetes and retinopathy would rate the quality of their life reduced by 35% or a QALY of 0.65. Asking a sample of patients with the same health problem similar questions and pooling their answers gives an average QALY for that health state. A rating index called the European Quality of Life 5-Dimension System is used in the 2 European studies focused on in this report. It's being utilized also in many cost-effectiveness studies. The EQ5D is a 5-item system that quantifies 5 dimensions of health, including mobility, walking, pain and discomfort, anxiety and depression, self-care, and usual activity. Individuals are asked to assess each dimension using a 3-level scale: no problem, some problems, and extreme problems. Additionally, patients are asked to rate their health using a visual analog scale of 0 to 100, with 100 as full health using a graphical thermometer. The EQ5D is then adjusted for the obvious, such as age, gender, race, ethnicity, and income. The utility value that results is based on a study where 3,000 of the UK general public were surveyed, asking them how much life they had hypothetically sacrificed to gain greater quality of life in a trade-off analysis. Then each of the potential 345 health states created by the combination of the 3 possibilities and the 5 dimensions was mathematically assigned a utility value. Complicated stuff to be sure, so how can we get a better handle on this? We will give an example using an online automatic calculator available at the University of Health Sciences in Oregon. Let's say you're dealing with one chronic condition, and we're going to choose that as intervertebral disc disorder. The patient is going to be a 55-year-old black male, and we'll leave his ethnicity as the default, living in the U.S. with a family income of $55,000. He'll have 4 members and an educational level of a high school diploma. Now let's calculate. Scroll down and you see the result is a utility score of 0.91. This is the QALY for this individual upon which improvement would be measured. What were the comparison approaches for this analysis? This was certainly dictated by the available evidence. For low back pain, they include medical physician care, chiropractic physician care, physiotherapy-led exercise, and manipulation and physiotherapy-led exercise. As you can see from the table, chiropractic care is associated with better health outcomes, but at an increased cost of around $76 compared to medical care. The incremental cost-effectiveness ratio is about $1,857 per QALY. Well, how was that arrived at? Look at the cost for chiropractic care. It's calculated by taking a standard visit at about $22 and multiplying the number of visits per year. The efficacy QALY is calculated by taking the difference in their improvement gained before chiropractic care and after, measured in quality of life improvement. To determine the cost of the difference between the 2 approaches, the incremental difference between medical care and chiropractic care, divide the cost difference between them by the difference in effectiveness measured in QALYs. So let's do the math. $2,355 for medical minus $2,431 for chiropractic equals $76 more for chiropractic care. 0.618 medical minus 0.699 chiropractic equals an effectiveness QALY of 0.041. So then you divide the $76 by the 0.041 and come up with $1,854 per QALY. It's a little different than the chart, but that's because they rounded off the numbers. Let's now look at the same approach for combining chiropractic care with exercise therapy. Combining chiropractic with exercise therapy would cost about $152 per patient more compared to medical care, with an incremental cost ratio of $4,591 per quality, still within the accepted value range of $20,000 to $50,000 per quality. Even when the Mercer team calculated increasing the average fee for chiropractic services to 5 times that in the study to about $100, the dollars per quality were still only about $20,000 per quality. For neck pain, using medical physician care as the standard, chiropractic physician care and exercise were compared using the cost-effectiveness model. Chiropractic physician care achieved better outcomes with lower cost, on average about $302 per patient. Chiropractic care is estimated to save $6,035 per quality compared to medical physician care. So, how would you communicate this to another healthcare professional, insurance company or managed care company, or a politician? Let's try. The Mercer report provides a nice overview of cost-effectiveness studies with a best guesstimate approximation of value for chiropractic care inclusion in the U.S. system. The cost data from Mercer is certainly extensive and likely representative of those expenses in the U.S. based on their access to 10 million patient lives. The cost-effectiveness data from European studies is valuable and positive in relation to manipulation for neck and back pain. The outcomes in these studies are based on a value-based measure, the EQ5D, and the resultant qualities. The difficulty is extrapolating without clear indications of method and statistical clarification, the amounts arrived at by combining these two elements, in particular when using qualities as the value measure. The Mercer report should be looked at as a valuable tool for establishing the current data for cost effectiveness and for providing an imagined benefit using existing data. A food for thought report that would hopefully stimulate a more scientifically valid measure of the value of universal inclusion of chiropractic in the U.S. healthcare system. For a more extensive explanation of concepts and application, the AMA publication Evidence-Based to Value-Based Medicine by Brown, and Sharma is a wonderful resource.